Thank you so much. I'm Dr. Saleh Al Hasnawi. I am Professor and Consultant Psychiatrist. I am retired from governmental work and I am now giving lecture in 2 medical schools in Baghdad and practice psychiatry in my private clinic. I will talk about psychiatric aspect of COVID-19. Next slide, please. How to move it? Pardon. Pardon. Is the slide shared or not, please?
Yes, Dr. Saleh. Yeah.
I have problem how to move the slide from one to another slides. How can I move it? Okay, thank you.
Oh,
Now it's clear. Okay, thank you so much.
Okay,
so
okay.
much. As you know, now we are facing Omicron, the new Omicron outbreak. And so now all of us see how the political authority, the health authority, and the business authority, all of them how react to the Omicron and what's the stress that all of them faced because of Omicron. So, various mental health problems, including stress, anxiety, depression, suicide, health anxiety, substance use disorder, domestic violence, and exacerbation of premorbid psychiatric disorder associated with COVID-19 infection, which occur either during infection, post-infection, and in non-infected people. Before we discuss what's the type of psychiatric disorders accompanied COVID-19 infection, let us take an idea about the etiology. Usually in psychiatric disorder, the etiology is multifactorial, which is biopsychosocial causes. If we look for the biological causes, first of all, that we face, we call it multiple biological factors due to infection. Which of them is electrolyte abnormalities, liver inflammation, impaired renal function, impaired oxygenation, all of this metabolic and biological disturbance that occur in the body because of the infection may lead to direct and indirect effect on CNS and then neuropsychiatric manifestation of this effect. The second proposed theory is that viral-induced immune reaction or autoimmune reaction. During the infection or after the infection, usually there is an autoimmune reaction. And this autoimmune reaction leads that to the virus to compromise the blood-brain barrier and the passage of the virus through this compromised blood-brain barrier through mechanism of immune cells that infiltrate the CNS and cause damage to the CNS. The third mechanism is vascular microcoagulopathy or coagulopathy. As we know, microcoagulopathy or microcoagulation or microembolism is accompanied COVID-19, and a lot of symptoms, somatic symptoms or body symptoms result from this coagulation process. And this coagulation process involves also the vascular system of the central nervous system and give its impact directly on the function of the nervous system, results in psychiatry and the neurological, psychiatric and neurological manifestation. There is one theory about the direct invasion of the CNS by the virus. These theories come from the loss of smell and loss of taste. Loss of smell, as they claim that the virus entered through the nose, from nostril, and then through the nerve ends of the olfactory nerve, and then directly to the olfactory bulb, and then to the olfactory center and involvement of the brain. This is the fourth proposed theory of the direct biological causes of neuropsychiatric manifestation of COVID. What is the psychosocial factors? A lot of psychosocial factors can cause psychiatric disorder associated with the infection. And here some of it, not all of it, like frequency and extent of exposure to individual infected with virus. This may create stress, create anxiety. If the person has depression, maybe increase depression. If the person has like OCD, that may increase OCD. So facing the patient, facing the infected person may be cause of psychiatric disturbance. Fear of infecting family members. One, like health workers or infected person, this increase anxiety and burden, psychological burden on him because there is a fear of infected family members. Lack of access to testing and medical care for COVID. In some countries, not in all countries, in some countries may create a big stress on the person. Physical distances, home confinement, and quarantine. All of this is stressful situation. Inconsistent messages and directive regarding public health measures, such as wearing masks, as we know, the debate about the benefit of wearing masks or not masks in the beginning of the pandemic. Increased workload, especially for the humanitarian persons and for health workers. Economic hardship and insecurity. Diminished personal freedoms. Continuous media reporting and sometimes wrong messages by media. Age, old age, isolated person, marginalized people, all these psychosocial factors and many others may be precipitating for psychiatric disorder and COVID infection. Let us start with an example about quarantine. What are the mental health aspects of quarantine? Many studies report higher prevalence of psychosocial symptoms, emotional disturbance, depression, stress reaction, anxiety, post-traumatic stress disorder, sleep disorder among those who have been quarantined. Long-term behavioral changes like vigilant hand washing and avoidance of crowd, which is obsessional symptoms, as well as delayed return to normality, even after many months after quarantine, were also reported. Consequence of quarantine on mental health, not only short-term, but also in long term. Mood and anxiety disorders associated with COVID infection. During and following COVID infection, patients are at increased risk for depression and anxiety. In one study, 1 month following the infection, depressive symptoms is about between 30 to 40%. Anxiety symptoms between 20 to 40%. And OCD symptoms is about 20%. And as you know, that the results of all the study that I will mention in my paper, the results are, vary between each another because of, the rate is vary because of first methodology, different methodology. Second, different population studies. Third is how long after the infection. It's maybe 1 month, 2 months, 3 months, and the criteria that used for the diagnosis of psychiatric disorder. So the numbers are not similar, and sometimes is different. There's a big difference between one study and the other studies. One prospective study of patient in New York City described symptom severity during hospitalization and 2 weeks after the beginning of infection. During hospitalization, 36% of participants reported anxiety and about 30% reported depression, while 14 to 17 days later, the prevalence of anxiety and depression decreased to 9% and 20% respectively. In another study, the findings that anxiety disorders around 13%, while depression is around 10%, which is not different from the normal population, and anxiety disorder is less than normal population. One important point that severe COVID disease always associated with higher risk of diagnosis of depression and anxiety. Depressive and anxiety symptoms following COVID-19 are more likely in female, in persons with infected family member, post-infection physical discomfort, in severe infection, and elevated inflammatory markers and pre-morbid psychiatric disorders. Suicidal ideation also elevated following COVID-19 diagnosis. In one study, about 3 to 5% of respondents reported suicidality at 1 month following the infection. Anxiety. Anxiety could be a reaction to infection, and this is the common cause of anxiety and the most frequent psychological reaction to pandemic. Several studies demonstrate that those who have been exposed to the risk of infection may develop anxiety. Anxiety may be directly related to sensory deprivation in quarantine life or in home isolation, especially for the lonely person, and pervasive loneliness. Social isolation also plays an important part in the development of anxiety related to restriction and lockdown measures are linked to feeling of uncertainty for the future, fear of a new and unknown infective agent, resulting in abnormally increased anxiety. Health anxiety disorder that we call it hypochondriasis, which is the definition of health anxiety disorder, misinterpretation of somatic symptoms. Here in COVID-19, misinterpretation of the somatic symptoms as sign of COVID-19. This may lead to performance decline in many aspects of life, developed in many people. Many reports demonstration that these individuals are more vulnerable than others to have health anxiety if they experience physical symptoms potentially linked to the infection, and fear that symptoms are directly associated with active infection even several months after the exposure. An example, like some person who have a headache and shoulder pain and abdominal pain associated with other symptoms of COVID. When he recovers, after a few months, when he develops headache, he misinterprets the headache as recurrence of COVID. So this, we call it as health anxiety disorder. Furthermore, additional tragic effect associated with anxiety in pandemic period may include perceived lower social support, separation from loved one, loss of freedom, uncertainty, and freedom. PTSD. PTSD is one of the most common psychiatric disorders diagnosed among COVID-19 survivors, with a prevalence nearly 40% at 6 months post-discharge. Today, the prevalence of PTSD among COVID-19 appears to range from 20 to 30%, while prevalence of less strict defined PTSD, as you know, we have narrow criteria and we have wide criteria. Narrow criteria give us a small prevalence, while wide criteria give us large numbers. So depending on the criteria we are used here, a less strict defined post-traumatic stress disorder, in one study, more than 700 clinically stable hospitalized COVID patients in China, 96% reported significant post-traumatic stress symptoms associated with COVID, not post-traumatic stress disorder. It's post-traumatic stress symptoms. So according to the criteria and the methodology that we are used, it may give us a prevalence of 30%, 50%, 60%. And if we look for the symptoms only, it may reach 96% as in China. While in one cohort study in a large university hospital in London, 4 to 8 weeks after discharge, only 31% have post-traumatic stress disorder. In another study in Korea, South Korea, patients interviewed approximately 2.5 months following hospital discharge, only 20% met the criteria of PTSD. Similarly, in another study, in cohort study in Italian patient who had been hospitalized for COVID, 20%, nearly 22.2, nearly 20% met criteria for PTSD 2 weeks post-discharge. In PTSD, there is risk factor, increase the vulnerability to have PTSD in COVID patient. This is our younger age, female gender, person who admitted to ICU, past psychiatric history, high rate of obesity, diabetes, metabolic syndrome, cardiovascular disease, and autoimmune disease. Substance use disorders. One report by CDC in June 2020 reported that approximately 10% of Americans had either started using illicit substances or increased the quantity and or frequency of substance use because of COVID-19 pandemic. Not surprisingly, it is anticipated there will be more drug overdose deaths in 2020 than any prior year. Screening for substance use disorder will be an important part of follow-up care for COVID survivors. Patients with substance use disorders are more susceptible to COVID due to the social and public restrictions implemented during the pandemic as compared with those without substance use disorders. Across all patients with COVID-19, those with comorbid substance use disorder are more likely to require hospitalization, 40% versus 30%, and die, 10% versus 7% roughly. Now we come to the people who have pre-existing psychiatric disorder, who have previous diagnoses like depression, anxiety, OCD, schizophrenia, bipolar, and so on. As you mentally challenged patients are substantially more prone to develop infectious disease and are at a considerable risk of experiencing more negative physical as well psychological outcome during potentially epidemic of COVID-19. This is because cognitive decline, poor awareness level, impaired risk perception, and reduced concern about personal hygiene can increase the chance of acquiring the infection on such individuals. Additionally, social discrimination against mentally ill makes the management of patients with COVID more challenging when psychological comorbidity exists. Psychiatric patients also prone to develop recurrence or deterioration of the pre-existing signs and symptoms of their disease. It appears that psychological effects of COVID-19 are adversely affecting many patients with a pre-existing mental disorder. An example, approximately 20 to 25% think they are coping poorly with and deteriorating. This in one study. In another study, a self-report online survey of outpatients with a pre-existing psychiatric disorder, which was conducted in China 2020, found that deterioration related to the pandemic was reported about by 21%. So 21% of the patients who have pre-existing psychiatric disorder report that their condition deteriorated. In another self-report online survey of individuals who self-identified as having mental illness such as anxiety disorder, unipolar major depression, or bipolar disorder, approximately twice as many were coping poorly compared with coping well, nearly 23% versus 12%. The majority had specific concern about the pandemic and their mental health, such as worsening their illness, around 64%, inability to receive treatment, around 40%. Anxiety disorder, there's increased risk of deterioration of patients with generalized anxiety disorder, patient with health anxiety disorder, patient with somatization disorder due to biopsychosocial factors mentioned before. OCD, there's a clear evidence that patients with OCD have deterioration in their symptoms following COVID infection. Many practice frequently self-monitoring of temperature, like self-monitoring of temperature, may several attempt to swallow saliva to check the throat pain as symptoms of COVID, hand washing, and many other obsessional and compulsive symptoms associated with OCD. Domestic violence and child abuse, lockdown, stay at home, pre-existing psychiatric disorder, substance use disorder, the risk of domestic violence, child abuse, elder abuse is increased. Substance use disorder, increase in the quantity and the frequency of substances because of COVID-19 also reported in many cases. Depression, depressive symptoms become more severe with COVID-19 infection due to biopsychosocial factors, depressed mood, loss of interest, sleep disturbance, preoccupation with death, suicidal ideation, or attempt with somatic symptoms. COVID may act as a precipitating factor for relapse of unipolar or bipolar, schizophrenia, or schizoaffective disorder and other psychiatric disorders. In schizophrenic patients, they are likely to suffer from pandemic based upon their social circumstances that put them at risk for poorer health outcome once infected. In addition to their cognitive difficulties and marginalized social status and poor judgment may impair their ability to follow public health regulations. My message is, don't miss mental state assessment in patients with COVID-19. Thank you for your attention and listening.